Hello everyone. Today I'll be talking about how do I really go around optimizing my ventilator every day. A vented patient is a complex patient and there's a lot going around him. There are ventilator settings, ventilator waveforms, the vital signs, and the patient itself. So the first thing that I do is look at my patient. The most important question that I ask is what is the sedation level? And one of the things that I look at is RAS scoring system. Does he needs to have this degree of sedation for the degree of hypoxemia? And can we come down on sedation? This is one of the questions that I ask every day. The second thing I look at is his respiratory status and how are his respiratory movements. Is he triggering the ventilator? And it's always good for the patient to have some spontaneous respirations. The other thing that you look at him, is there any vent asynchrony? Thirdly, I look at how his respiratory pattern is. Is he dyspneic? Is he using his accessory muscles? Is he flaring his nose? These patients are in severe respiratory distress despite the sedation level that you are giving them. Next, I look at the O2 sats. The question I ask myself is, can I come down on the FiO2? So here the patient is setting 98% and he's on 100% FiO2. So it's always good to titrate down the FiO2 to target your sats of around 90%. Third thing is I look at the waveforms of the ventilator, and the question I ask is my flow rate coming down to the baseline? In this case, it is not. That would suggest that the patient is developing some auto PEEP, and I can perform an expiratory pause to figure out how much air trapping there is. And then the next question you have to ask is, do I need to adjust the respiratory rate or the I time to get rid of it? Here we can drop down the respiratory rate till the flow reaches 0. The other thing you look at is there any ventilator asynchrony? The next step, I look at the peak and measure the plateau pressures. The question I ask is my plateau pressures more than 30? And in this case, yes, it is. And if it is, I would like to come down on the tidal volume. As you can see, we started at 6 cc's per kg, but given the plateau is higher, we'll come down on the tidal volume in steps till your plateau is less than 30. One of the other questions I ask myself is, what is the driving pressure? I might want to bring down the driving pressures even further. I'm aiming for driving pressures around 15 centimeter of water. While I'm dropping the tidal volume, I'm keeping at the back of my mind of decreasing ventilation. And the question I'm asking myself is, do I need to increase the respiratory rate for the drop in the tidal volume I just did? Other thing I look at is compliance and want to compare the compliance from yesterday and see if that is getting any better. Lastly, I look at the resistance part of the circuit. That means looking at the peak minus plateau and seeing if it is less than 10. If not, I would like to know what's really causing it. Most often the patients would have some COPD or asthma or some obstructive features, and I would make sure that they are on albuterol. And if this is pretty high and they are in COPD exacerbation, they might be given steroids as well. The other thing this will tell me is if the tube is kinked or if there is mucus plugging around the tubes. That means the tube diameter is getting smaller. Next thing I look at my PEEP. And the question I ask myself is, do I need to change my PEEP? If my FiO2 is low, the question is, do I really need this high of a PEEP and can I come down on it? If my FiO2 requirement is high, I look at a couple of the methods, especially the static compliance method and evaluation of stress index to figure out if that PEEP need to be changed. I also look at the PV loops to give me a better idea of how PEEP should look like. Lastly, I examine the capnogram, especially in obstructive diseases, because it gives me a very good idea about the dead space component of the circuit. For this, you would need an ABG to give you the PaCO2, and if the morning ABG available, for example in this case PaCO2 is 40 and end tidal might be lower than this, I can calculate the dead space and I can trend it out for the past few days to see if my COPD exacerbation or my dead space component is looking better. Lastly, if there is an ABG available, I will examine it. The important part of looking at the ABG and the ventilator setting changes is the ventilator-induced lung injury prevention trumps the need for correcting the numbers. The number that I'm interested in is keeping their oxygenation okay. That means PO2 of 55 to 60, and which corresponds to SAT of 88 to 92%. I tolerate hypercapnia, and I avoid changing the rates for hypercapnia for mild acidosis unless we have air trapping issues where the air trapping can cause more trouble. So try to resist temptation to normalize the numbers unless the patient will benefit from changing those settings. After changing, it's advisable to get an ABG. However, if you have got pulse oximetry and end tidal monitoring, that would give you sufficient idea where your new ABG should look like, but get one if you make a lot of significant changes. In this case, our new ABG shows a pH of 7.26, PSU2 of 56 and PO2 of 61, and to me that is a beautiful ABG, and we'll see how this patient does. Thank you. Hope you learned something from this video.